All right, good morning, everybody. It's time to get started since it's 7 o'clock. I know a lot of you need to get to pre-op holding at 8 o'clock. So we're going to go ahead and start grand rounds this morning. We have a very interesting combination of presentations this morning. First up on the docket is Dr. Heiko Yang, who is a brand new assistant professor of urology in that division. By way of introduction, he did his undergraduate work at Yale University, and then he went on to Michigan, where he did an MD and also obtained a PhD in cellular and molecular biology. And then he kept traveling west, where he went to San Francisco to UCSF, where he did his residency in urology and completed a fellowship in endourology and advanced laparoscopy before being recruited by Dr. Meacham to come to Denver and join the division here. His academic career has started off very well. He's already been presenting many abstracts and publishing papers and manuscripts. And so today he's going to talk to us about normothermic ex vivo organ perfusion. Dr. Yang.
Okay, good morning. Thank you for that wonderful introduction. Let me just make sure I understand how to toggle here. And that is because I like to start most of my talks with a video. I believe the sound is on, so please pay close attention. I hope everyone caught that. I'm really excited about this. This is a pig peeing. Now, before you're like, oh, this is a weird urologist, who's really into animals peeing, I will tell you in a moment why this pig peeing is very important. So I'm going to be talking about normothermic ex vivo organ perfusion. Here's some learning objectives. Mostly what I want you to take away from this talk is that, number one, this isn't science fiction. This is, many of you are probably familiar with this technology, but for those of you who aren't, this is actually happening. And then number two, I want to stimulate your imagination about what's possible with this technology. I have a few disclosures, mostly with the work that I'm going to be presenting. I do have a couple of provisional patents. We are interested in commercializing some of this technology for reasons that will become very clear. Okay, normothermic ex vivo organ perfusion. What is it? We got to define the terms first. Normothermic means, normothermic means body temperature. Ex vivo, so in contrast to in vivo, which means inside the body, ex vivo is outside the body. Organ, there are many. This just so happens to be my favorite organ, the kidney. And perfusion, which is the delivery of oxygen and nutrients and the removal of waste products, typically through the blood. When you put it all together, essentially what we're doing is keeping organs alive outside the body in a relatively physiologic state. Now, why do this? Why normothermic ex vivo organ perfusion? Well, as of yesterday, there were about 100,000 patients in the US waiting for an organ transplant. Kidney is at the top of that list, followed by liver, heart, lung, and pancreas. Most of these patients will die before they ever get a transplant. And so there's an immense need to make organs more available. And having normothermic ex vivo organ perfusion technology is one of the ways that we can increase the preservation or improve the preservation of donor organs. Now, a few slides ago, I mentioned that I am a urologist, and specifically, I'm interested in kidney stones. So you must be wondering, why is a guy doing kidney stones clinically telling you about organ transplantation? Well, while I do care deeply about organ transplantation, I also care about the 500 different monogenic causes of kidney disease, many of which are related to kidney stones. And also, I think that there is a great need to have a better way to model human kidney biology. So for each of these needs, each of these problems, normothermic ex vivo organ perfusion technology promises a solution. So first, I'm going to tell you about what's happening right now. What is the state of the art in organ perfusion? Some of you may recognize these devices. On the left, this is the TransMedics organ care system. On the right is the Organox. I believe they call it the Metra. So these are the two major commercial products right now being clinically used to perfuse organs for organ transplantation. This technology, or at least these companies, have been around for a while. TransMedics was founded, I think it's out of Massachusetts. They were founded in 1998. Organox is out of the UK. They were founded in 2008. So 20 plus years of this technology. It's been taking some time to get traction and to develop the technology to the point of FDA approval and being used clinically. But as of 2023, about 10% of all liver transplants used normothermic perfusion. And liver is currently the most frequently used, is the frequent use case for these devices. So what is the benefit of using these devices? I'm not going to go too much into detail with this, mostly because I'm not a liver transplant person, but I will tell you at the basic level, the most practical benefit of using a device like this is that you can prolong the viability of the organ. So liver on a pump can last for 12 to 24 hours versus 6 to 8 hours in cold storage. And that could mean the difference between having to show up in the middle of the night to perform a liver transplant versus waiting until the next day. It can also mean the difference of being able to deliver that organ a couple hundred miles farther to reach the right patient. With the liver on this pump in a physiologic state, you can also assess its function. You can look at bile production, you can look at lactate clearance, transaminase levels. And this is very important, especially for higher risk donor organs. I believe they're called the extended criteria organs, where you're not sure how it's going to do when you put it into a recipient. And finally, we know that normothermic perfusion does improve the outcomes for these patients. You can have, or it reduces the early allograft dysfunction rate significantly, and these patients generally do better after they receive their livers. So this is really great for liver transplantation. So how about kidneys? How is this technology being used for kidney transplantation? Well, the reality is kidney transplantation is way behind in terms of use of normothermics. There was a large clinical trial looking at normothermic perfusion versus static cold storage. They compared static cold storage with just 1 hour of normothermic perfusion. Essentially found that, well, it's not really better, it's not really worse, just eh. So there's a little bit of a disconnect here. And I will tell you, I don't think in terms of in clinical practice, normothermic perfusion is actually being used widely in kidney transplantation. And I told you that there are 10 times more patients waiting for kidneys than livers. So what gives? Why isn't this technology being developed more or more quickly for kidney transplantation? And I think the problem really has to do with who's working on it. So this is the map of the world. The two green stars represents basically the only two places in the world that has any sort of robust kidney perfusion research program. And that is the University of Toronto and the University of Cambridge. If there's only two places in the world working on this, how can you expect the development of this technology to advance at a rapid pace? You can't. Then the follow-up question is, why aren't more people working on this? I just told you that this is such a great transformative technology. Surely everyone must be interested in this. Well, there's a few practical reasons why. Number one, it's expensive. It's really hard. And the current technology actually isn't optimized for the kidney. So you have essentially I'm telling you there's two major problems. One is this technology is not accessible. And if it's not accessible, it's really hard to improve. So for this next part of my talk, I'm going to be telling you about our experience trying to solve these problems. How can we make this technology more accessible, and how can we make it better? Okay, part two, the kidney in a bag. I can't tell this story without, or I can't tell it properly without introducing my mentor, Marshall Stoller. Marshall Stoller is a very famous urologist at UCSF. He basically wrote the book on kidney stones, and he is also a bolo tie enthusiast. This is a photo of me and Marshall after one of his busy clinics when I believe I was a fourth-year resident. In the course of our research on kidney stones, we realized that we really needed a better way to model human kidney biology and all of its complexity related to kidney stones. So one day I turned to Marshall and I was like, hey, I've heard about this whole normothermic organ perfusion thing. Why don't we just try it out for ourselves? And he's like, sure, why not? But you got to talk to my friend, Alan Flake. Alan Flake is a pediatric surgeon at the Children's Hospital of Philadelphia. He is the inventor of the artificial womb. Surely Alan should be able to help us get started. So we emailed Alan Flake. We said, hey, we have this idea, a little crazy. Do you think you can help us out? Within a couple of hours, he actually responded and he said, hi, Marshall and Heiko. I actually just arrived in San Francisco for a conference. So hopefully one or both of you will come to the conference and we can talk. I took this as a sign that this is going to happen and we're going to do this. So I cleared my schedule, went to this conference, talked to him and said, hey, can I spend a couple days in your lab in Philadelphia and try to get this thing up and going? And he said, sure, why not? So 2 months later, we were at CHOP in Philadelphia and we did our first experiment.
Okay, our kidneys in a bag.
That's my evil laugh.
That's what this project's gonna be called, kidney in a bag.
Kidney in a bag. This is a good picture.
Yeah.
All right, so get a picture of Alan and I.
So as you'll notice, no one told Marshall that he was wearing his gown backwards, but that's neither here nor there. But this is our first kidney in a bag experiment. It lasted 4 hours, totally bled out from the hilum, but it made a liter of urine. This was amazing. We were so happy. When we got back to San Francisco, we realized, well, look, this was a great one-off experiment. Alan Flake's got these great facilities, this great well-established lab. We still haven't solved any of these problems that we identified. Again, it's expensive, it's hard, it's not optimized for the kidney. So we realized that we were going to have to solve these problems ourselves. So problem number one, it's too expensive. So if you actually look at the sticker price for these devices, Transmedics and an Organox, for any new investigator trying to enter this field, someone interested in organ perfusion, this is a prohibitive cost. No one has, especially in this funding climate, no one has this kind of change lying around. So we had to ask ourselves, does it have to be that expensive? So what's in a perfusion circuit? I mean, it's quite simple, really. There's a pump, there's an oxygenator, there's some tubing, you have to put the organ in something, and then you have a bunch of monitors and analyzers, and they can be as simple or as complex as you need them to be. So if you are at a large academic medical center, and if you know who to talk to and where to look, all of these components are lying around, and you can get them for free, which is what we did. So this was our first circuit, and all of these components were basically, obtained for free. So great, we solved the cost problem, at least temporarily. So number two, it's hard. The problem number two is that it's technically challenging. There's a lot of logistics. There's so many different considerations, and you don't even know when you begin what is important and what kind of skills you need. But we're all surgeons here, and we're surgery adjacent, and we all know that in to do something that's hard, you have to practice. So how are you going to practice? Well, I'll tell you first, you have to use an animal model, and you're not going to use, at least when you're practicing, you're not going to use laboratory animals. Why? Because every laboratory animal, every experiment that you do is going to be thousands of dollars. I just told you about the cost issue. That's prohibitively expensive. So how can we find an ethical and also sustainable way to practice? So this is a pig farm in the Bay Area. I called several and basically said, hey, when you guys slaughter your pigs for basically for the food chain, what do you guys do with the organs? What do you guys do with the blood? And this place said, well, we just throw it away. I was like, oh, great. Do you think I could just come down and pick up some of these organs and blood and use it for my perfusion experiments? They're like, yeah, no problem. Just, stay out of the way. I'm like, okay, no problem. So this is literally at the farm.
These are the eviscerated innards. You got the kidneys.
They have removed all the entrails, put them on a table. They're like, okay, go have at it.
So here's the aorta. I'm going to get the artery
dissecting
as
the
close to
kidneys
the
out.
aorta as possible.
And you can hear the roosters crowing in the background.
Like this.
This is a real farm.
Okay, so I think here's the IVC. And then
So
what
we
I'm actually
typically
gonna
try
do,
to get
I'm
these
just gonna
organs
take a cuff of the
within
IVC
about
off.
10 to 15 minutes of the animal being slaughtered,
Kidney.
so that the organs are relatively fresh. And I bring it over to the station and I flush it with
And
cold
this is going
storage.
to be the UW solution.
And then once it's flushed
You're
with
in
cold
the
storage
artery.
solution, put it in a bag, bring it to the lab, and we can do our experiments.
So, you
So
can
this
see
is
the
what I
kidneys
did
start to
basically for a year.
expand.
Now that we have a way, first of all, we have a circuit and we have a way to practice with a lot of different organs. There are a lot of challenges that we can solve. Number one, cannulation. How do you cannulate these things? We first started by using the very expensive Mackay cannulas that are being used for heart or liver. And we realized we don't need to get that fancy. These are Lure-Lock connectors. These are Lure-Lock tubing connectors that are about 25 cents each. And they have a nice little barb at the end. You stick it in the artery and then you just tie it. And and it doesn't leak. There's no problem. Very simple.
This extra tissue in there.
Second problem, what do you do about hemostasis? These organs, as you know, they're not surgically dissected out, right? They're just ripped out of an animal and plopped onto a table. So there's a lot of different bleeders. And so in the beginning, we had to find a way to stop all these bleeders.
It's a good problem to have.
We tried all sorts of things. We tried tying them. Here I am using a ligature, trying to bipolar around the hilum to prevent it from leaking, essentially. Eventually, I mean, this took added an extra 30 to 60 minutes per experiment. Very precious
Trying
time.
to do it correctly.
And then we eventually realized, oh yeah, I can stand a little bit closer to the mic here. And then we realized, basically, well, what's the point? I mean, if it's going to keep leaking, we spend all this time. There's no way to gain perfect hemostasis. So what are we going to do?
Kidney?
We're just going to put it in a bag, and we're actually going to add a little drainage
And
bit to
that
recycle
here,
that back into the
Actually, it's
reservoir.
hard to see.
So this saved us a lot of time. And here you can see our initial learning curve. This is the first 17 experiments that we did. And you can see, so this basically documents whether or not we were able to get urine production. So that's what the O's are, the X's are. Well, unfortunately, didn't produce any urine. And then on the X-axis, this is the amount of time that we were able to perfuse these kidneys. And so over the course of 17 experiments, you can see that we got better and better with getting urine production and also extending the duration of the perfusion. This is our learning curve. We see improvement. Okay, now that we have made this more accessible, at least to ourselves, now we want to make it better. So I mentioned that the current technology is not optimized for the kidney. So how are we going to optimize it? Well, first we have to understand, what is the problem? What is the problem? Why isn't the existing technology optimized for kidney? And it's really just simple physics. So the kidney, relative to heart, lung, liver, is a much smaller organ. And more importantly, the blood flow that it accommodates is actually much lower. The number here, the 0.5 liters per minute, this is actually an in vivo estimate in humans. And it's very generous because in ex vivo, conditions, the actual flow rates that the kidneys can handle ranges somewhere between 10 and 200 mils per minute, so much lower than the half liter per minute. And why is this a problem? Well, even the smallest commercially available oxygenator needs a minimum flow rate to work properly, about 0.1 liters per minute. So if you do every experiment setting the flow rate at 0.1 liters per minute, about half the time, you're gonna blow the kidney out. High flow rate, high resistance in the kidney, high pressures, and it basically just hemorrhages everywhere. So how do we solve this? We basically had to design a bypass loop that had a pinch valve that allowed us to differentially regulate the flow and pressure both through the oxygen, separately through the oxygenator and the kidney. And once we did this, we were able to solve the problem of blowing out the kidneys. And I do want to mention one of my very talented PRAs, Natalie Meyer, did all the artwork that I'm going to be showing in this talk. So when we redesigned the circuit, that was truly the inflection point, at least the first inflection point, of being more successful in doing these kidney perfusion experiments. Now, this project is called Kidney in a Bag, so I would be remiss not to talk about the bag itself. The bag, I'm very proud of the bag. I feel like it's pretty clever. It's basically a 3-liter cysto bag. You know, when you do a cystoscopy, you have that 3-liter bag of saline. We basically converted one of those. You can put a kidney in this bag and then you can secure it with magnets. What do the magnets do? Well, the magnets stabilize the hilum. If you don't stabilize the hilum is very floppy, the tubing will kink. And essentially you need to babysit the kidney constantly in order to prevent that from happening. With this system, you put the hilum on stretch, you stabilize the cannulas, you have no problems with kinking. And the second part of it is that the magnets are fenestrated. And so any sort of hemorrhage that leaks around the kidney can leak out, and you have a drainage port at the bottom that goes directly into the reservoir. And this is what that looks like in real life. So one question you might be having is, well, we talked about normothermic perfusion. This bag, I mean, it's out at room temperature, it doesn't have great insulation. Can you actually get the kidney to normothermia? Yes, turns out if we warm the perfusate through the oxygenator, it has these, you can run warm water through that, so the blood gets warmed, and the blood will then warm the kidney. And within 20 minutes, in almost all of our experiments, you can get the kidney to normothermia within about, like I said, 20 minutes. So we've designed a circuit, but more importantly, we've also designed a process, a protocol for doing these experiments, starting from the harvest of the organ and the blood, to setting it up in the lab, to processing it, to finally getting it on the pump and doing it. And so we were able to do this many times over the course of the last couple of years. And this is one of our more recent experiments where we got it to 24 hours. And you can see what the kidney looks like after about 24 hours. A little bruise, you can see that's our bag. There's still some blood leaking around it, and that's fine. I'm actually going to skip through the rest of this video. But I do want to mention I have another PRA who they're also very talented, who basically stayed overnight. So each of these 24-hour experiments, 36-hour experiments, you need someone to provide ICU level care to the organ. And very luckily, I have people who can do that, which is amazing. Okay, now we've done this. How can I convince you, or how can we convince ourselves that these kidneys are actually alive and viable? As you can tell, I really love videos. This is very subtle. Look at the ureter. Look in the middle of the screen. There. I hope you guys all caught it. So that's the ureter peristalsing on our normothermic perfusion pump. This is 6 hours after we started perfusion. So the ureter is wiggling. It's able to do its thing. Now, of course, it's a kidney. What does a kidney do? It makes urine. And so it's a very easy functional test to see whether or not the kidney is working. In addition to just a amount of urine that it's making, we also look at what's coming out. Is it clearing creatinine? Is it clearing potassium? And the answer in both cases is yes. We can give it Lasix while it's on the pump, and we can see that the urine output goes up. And we can also do, in my mind, the killer experiment, which is perfuse it ex vivo, then put it back into the animal and see if it continues working there. That is the ultimate proof of concept. And so that's what we did. So we designed an animal experiment where we do a nephrectomy, put one of the kidneys on the pump for 24 hours, put it back into the pig and remove the other kidney. So it's completely dependent on the auto-transplanted ex vivo perfused kidney for renal function. We followed it for 2 days and we wanted to see, is it making urine? Is it doing well? Did it pee? So this is our 24-hour experiment where we auto-transplanted it. We have pee pads under the cage to basically catch any urine that comes out of the pig. You can see that urine spot on the bottom left corner there. We can do an ultrasound. We see that the flow to the kidney is good with a reasonable resistive index. And I know most of you are not renal pathologists here, but I will tell you that on necropsy and doing the histologic assessment, this looks really good. So these kidneys are doing well after reimplantation. Okay, so we've created a process, we've made this more accessible, and nominally, we've made this technology better. For now, the next question is, so what and now what? What can we do with this? So I'm going to go back to the beginning of my talk and talk about the reasons why I'm interested in developing this technology. So I mentioned that there are 500 different causes, monogenic causes of kidney disease. Polycystic kidney disease is one of them. And so now we have a tool to perfuse these kidneys, to study them, and to figure out how to deliver gene therapy to these kidneys. So this was a polycystic kidney. Dr. Pishak actually just removed this last week and we put it on the pump. And what we're doing with this kidney now, this is clearly not going to be a kidney that we're aiming to eventually auto-transplant back to the patient. But it's a very important research tool because it allows us to develop, kidney in a tub. This is what this project is going to be called. It allows us to develop CRISPR tools using primary human kidney cells, and then also develop routes of delivery, whether it's in an AAV or a lipid nanoparticle, to put those things back into an organ. With the eventual goal is that for polycystic kidney disease patients or patients with any other sort of monogenic kidney disease, we can develop a cure. The second thing that we're very interested in, and a problem that we're very interested in solving, is the reliance on red blood cells for perfusion. This is a universal challenge in organ perfusion. What's so bad about red blood cells? Well, red blood cells hate being in a mechanical circuit. This is one of our experiments. This is from our 24-hour perfusion. You can see when we spin down the blood, you can see it start turning yellow, orange. Eventually it turns red. And what is that? That's hemolysis. The red blood cells degrade very quickly in the mechanical circuit. And while it's maybe not so deleterious or not that big of a deal for other organs that can handle free hemoglobin, like liver, particularly the liver, which processes these waste products, it's really toxic to the kidney. And I will tell you that I think the main reason why folks haven't figured out how to extend kidney perfusion is because of this toxic effect on kidneys in ex vivo perfusion. So we need to solve this problem. And the way we solve this, well, I'm going to let you in on a little secret. So this is one of the first photos that I showed. The red the red stuff in this perfusion circuit, it's not actually blood. Oh, sorry. Okay. It's not actually blood. There's no red blood cells in here. What we're perfusing this kidney with is actually a oxygen carrier derived from an earthworm. So we did this experiment. We perfused this kidney for 24 hours. We put it back into a pig. And this is the pig peeing post-op day 4. That's why this is so exciting. This pig survived for 7 days and had a normal potassium on day 7. Okay, so in conclusion, I think this is really exciting. We've solved some problems to make this more accessible and feasible, and we can do this at scale, and most importantly, we can do it here. Thank you so much for your attention. So sorry, I was looking at this.